So thank you. Hopefully everyone has gotten their lunch. I am so pleased today to introduce Dr. Michael Reede. And I'm going to read a little bit about him, which is amazing. But I have to also start out by saying I first met him early on in my tenure here in this kind of role, part we all have multiple roles, when you came to speak, which was a while ago, and it was impactful, and gave me an example of what excellence looked like in leadership. And then at another time that he probably doesn't remember, we were both speaking at a conference in California and trying to help people understand that racism is ever prevalent. And I remember you taking the audience, the attendees, through a process of trying to go through TSA and asking how many times people have been stopped. And it was fascinating to watch sort of who was standing at the end.
Yeah.
And they all look like us.
Yeah.
At that. But the example, not just of data and showing pie charts, but the example of lived experience. And so with that, today we're joined by Dr. Michael Reede, who was appointed the 21st president of the University of California, where he oversees a world-renowned system and 10 campuses, 6 academic health centers, 3 nationally affiliated labs, and more than 290,000 students and 230,000 faculty and staff. President Drake also holds faculty appointments at UCSF School of Medicine as professor of ophthalmology and at UC Riverside School of Medicine as a professor of medicine. He led the Ohio State University, and I learned that I always have to say the Ohio State University from 2014 to June of 2020. And prior to OSU, he spent his entire academic career at the University of California, including 9 years as chancellor of UC Irvine, 5 years as the system-wide vice president for health affairs. He earned his AD from Stanford, like California, and his MD in residency training at UCSF. And he's also got connections to us through this role and his leadership with the Commonwealth Fund. President Drake, thank you so much for being here. Please join me in welcoming. So I'm going to start out with some basic questions, but really helping us to understand how your early experiences and awareness of health equity or inequities, where you learned about them, how you started thinking about them, how it was related to where you grew up and the times when you grew up, which is during the civil rights movement. Which I have to say, as I think about the civil rights movement, I don't think it ever ended, but it's interesting when people start to say the civil rights movement back then, it's like, what do you think we're in now? But it's a different issue.
I'm going to stand up just and look at everybody for a second, so I know who I'm talking to, so we'll get like a human being visual image. Okay, and then I'll go back there, but I wanted to have us connect as human beings since we happen to be here. Nice to see you all. You look actually pretty good. That's great. So thanks, first, feeling great to be here and to see everyone. Always like coming to Boston. I was a fellow. My glaucoma fellowship was here, so I lived here for a while. And then I had a little stint here years later that was a career trajectory changing stint that I didn't realize was a career trajectory changing stint at the time. So we can touch on that a little bit later. I was born in New York City. My father had just finished internship. He actually days before I was born, so he finished internship. And then we moved soon thereafter with my father, brother, older brother, and sister to Englewood, New Jersey, so just across the George Washington Bridge in New Jersey. And grew up there then in the late 50s, 60s, and just to Joan's point, where I grew up was entirely segregated. So not like a little bit or whatever, just entirely segregated, so that was the norm. I picture I like at my elementary school, 100% of us were black. But it was then that was the norm. And so that was the life that I knew growing up. There's a how many of you know Englewood? If I say Englewood, New Jersey, how many people know that name? It's a place. It doesn't make much news, you know, when you get west of maybe the Hudson River, but it doesn't go far. But you know, there's Englewood Cliffs, and so there's the jazz connection of Englewood Cliffs. So that when I was growing up, that was sort of called the Hill. And the idea in my mind as a child was that the Hill was like a different country. And if we would drive there for some reason, it was only to pass through. But if I could share the image, it was almost like I wanted to get a little smaller in the car to make sure that we were, you know, kind of get through and get to where we were supposed to be. So I kind of had that as a baseline upbringing. And then we moved to California. My father worked and had a practice in the house, which we can talk about, but a bit later. But then went back to residency, did a psychiatry residency, and then we finished that and kind of for a good day, and we moved. Yeah, that was a cheer for California or for psychiatry. Two together, and we moved to an entirely different world for me, which was the Sacramento, California. This was kind of the suburbs, and we moved to a nicer neighborhood, and that meant then rather than everybody looking like we did, everyone looked different. And also there were Asians and Latinos, which there were zero of in my experience, except for TV when I was in New Jersey. So that was a change. And it meant that I then grew up in a place where I could feel what it meant to be different on a daily basis. And so that sort of formed the basis of my understanding of the fact that there were differences in the world, and then we could see the way that people were being treated on a daily basis. Now that was different, and it was just an interesting way to go through that. That there was the time there was the Martin Luther King version 1960 civil rights movement. So all those things are very prominent in my growing up. So I knew of those. I knew of the separations in our society from the time I was a child. I felt them every day as I was growing up. When I went into medicine, the change for me was that I didn't go to Meharry or Howard, which is where I thought I was going to go when I was in high school, where my father had gone. And but I went to UCSF instead. I went to Stanford instead of going to Morgan State or whatever, where my parents had gone. And so there were different opportunities, but always in this kind of spanking brand new crest of a wave change in the way the world was oriented. So let me stop there and just say that was kind of that's the baseline.
Let me ask a question within that, because I think sometimes there are assumptions made about the quality value hierarchy of different kinds of institutions. But part of what I'm hearing you is a Howard, a Morgan State, as being stellar institutions, high quality education. In your parents' experience, you Stanford and UCSF, high quality. But can you speak a little bit, because sometimes people make assumptions that if you're going to a non-majority or a non-Ivy or a resource-rich institution, those are the only places where you can get that quality education.
Yeah, so in the growing up time, then there was no choice. So you know, we talk about selectivity in institutions, and a lot of things we can talk about, but one of the things that sort of the U.S. News ranking of quality in the world is based a lot on exclusivity equaling selectivity. So the higher the qualification of the people you can say no to, the better you are. So it's about who you're saying no to really than about who you are, which I think is, what's the word, bass acrid, that's a California word. But it's selectivity. When I was going back to the old days when my father was going to medical school, if you were African American, there were about 100 slots in the country. So it was, you know, you were so, gosh, yes, it was, but that was it. So they were extraordinarily highly selective. and extraordinary people who all had to work to get to where they were going. They didn't happen to be there, or you didn't back into it. You know, you had to decide that you were going to do something that was different. So that was like a great aspirational goal. In the period after Martin Luther King's assassination, all of a sudden places that had been closed, to also use the term us, forgive me, but the closed us forever were now open. And it was actually nice for me, I thought at the time. It was, well, great, here's something new to do in terrific places that are actually close enough to home that I'd gone through school a little younger than I was supposed to, or probably should have. But so it's a very nice thing to be able to do that. And the experience of I use Stanford in particular, 50 years ago now. Experience of Stanford was a lot like the experience of New Jersey to Sacramento, where it was you were the crest of a wave. There'd been nobody like you before, and was nobody, very few people like you there now. And so I know Brian, my classmate, is here. We finished school at the same time, Brian Swan, and we were at Stanford first at UCSF. You felt like you were, I'll use a California term, it was like you were surfing on the crest of a wave. You're really out in front of it, and everything you did, you were the first to do it. And there's no road now. That continues for me until this moment. I'll say it's been that way. You know, it's been my whole life career. Been trying to been doing things where there hadn't been people like me who've done them before. So that was an interesting continuation of that grade school through today.
When you think about your upbringings and your family, the people that you met or your teachers or however, what are some of the things that enabled you to step into that way, to be able to not just step in, but also be successful?
So so first I'm trying to be semi-relevant to what your questions are. And I'm saying that the inequities were built into everything. It was a normal part of it that there were inequities. In medical school, I knew of the inequities and, you know, the economic and other things, inequities. I could see it and feel it walking on the wards. And I remember that we, how many people here had, I'm just curious, UCSF experience at all? Just, I know some us would have. So as a medical student, you know, you were at the San Francisco General, you were at the Moffitt, the University Hospital, and the VA. And I remember seeing different, sort of similar types of diseases in different places, but the patients who had them look, the black people with the diseases were younger than the white people with the same disease. And so we went to the county, we saw diseases acute and with poor and people of color. But many of the diagnoses were the same, but they were just younger than the people at the University Hospital. And, the VA was kind of in the middle in a lot of ways. So it was kind of the average, but I remember seeing those life disparities, circumstance disparities sort of play themselves out in the manifestation of things that we were challenged by. I have a dear friend who passed away recently. Somebody who I loved, meaning the word LOVE, love. Woman named Nancy Admiral, if I knew Nancy, but love Nancy. Nancy was a psychologist that died, 3 months ago, 4 months ago, psychologist. And she worked on a kind of a ladder of opportunity. And she kind of pioneered the field of health psychology. And so she's lauded for this. But what she worked on from the 1970s on was, I think, sort of showing that the things that describe the circumstances of your life also kind of predict the circumstances of your life, and they're all connected. And so we spoke of the inequities that I grew up living through and with, and then as I was doing my training, I saw them manifest themselves in the ways that we are used to on a daily basis. So and you asked a different question, but that was my answer is that I always, my parental sort of training was that I was supposed to do a good job, you know, and or do better, I think was how they said supposed to, but And so I had that as an expected pathway. And then I'm going to close on whisper this a bit. You know, I kind of liked it. I mean, I liked school and science and things. I mean, that was fun. And then I like people. I enjoyed I was social in those ways. And so those things together kind of helped to create a pathway that this was fun and a good thing to do. And I got a chance to work with people, so I kept cycling or something.
You talked about this exposures, this sort of Inglewood versus Sacramento and those kinds of things. And seeing inequities in different places. What drove you to say that you wanted to do something like that? It's a part of observing and witnessing versus I want to step in.
Yeah, gosh, I guess the medical doctorness, so I was I'm gonna check and I'll write you a therapy, check you. So this is my father's a medical doctor and, he had a practice in the house. He was a football player in college, captain of a national championship undefeated team. I have his trophy from 1933 on my wall in my office today. And my mother was the dean's secretary of all the students, so they were kind of a power couple in, you know, in the 1930s at their college. And, but he in particular was, 6'1", 200 pounds back in the day, always in shape. I'll say this nice thing about him, but he's gone now, but he stayed in practice till he was 99. He worked all the way through. He worked out all the way through it. I know the day before he died, he actually took a day off that day before Christmas, 2 days later. But he was always doing work, and he had when my mother passed away, I've been married 70 years. My mother passed away. He had slowed down practice to take care of her at the very end. She passed away. We thought, well, he's going to go soon. Instead, he went into the garage and literally got the shingle that had been on the house in New Jersey and hung it up outside the house in Sacramento and started seeing patients in the kitchen. And kept doing that and was working out on his walker, with a walker walking around the court to get his steps in the day before he died. And so he had that as a kind of stay in shape, work hard, big guy approach to life, which is the same word about him. I was a little born maybe 5 weeks early. I was 5 pounds something. I had asthma, so I was skinny and not had all kinds of football memorabilia. The best I was to do is be a fan, I learned the rules that it's best we gotta get. But my upbringing, they're smokers in the 1950s, smokers now, I was asthmatic. And because the office was in the house, the refrigerator was the pharmacy. So the epinephrine and whatever were in the refrigerator. Syringes were boiling on the stove every night as a normal thing. And so when from time to time I have a bad asthma attack, instead of going to the ER, I go and wake him up. And then we go down into the kitchen. And so I remember I'm 5, 6, 7. But I didn't want to bother them in the middle of the night. So I kind of go and stand in their doorway to see if it would go away. And I don't know how long I'd stand there, but it seemed like I'd stand there for an hour or something, 2 in the morning. And but it wouldn't go away. And then I go and wake him up. And we go down and then I get the shot, and then a minute or 2 later, I don't know if anybody's asthmatic and had epinephrine, but or now we're modern the way we give things, but so it's a couple things from that. One is I learned that medicine works, because going from you can't breathe to you're okay. You said, well, it's actually I really learned about the power and the ability of medicine. The other thing I learned, I had to think about this later, was that I didn't want to wake him up, but he didn't mind. He was actually happy to get me better. And So I always had that feeling with treating patients, that it was like a blessing and an opportunity to be able to work with someone and help them get better, that was a great reward. And then that in that, you would look toward those places where people need the help. So some of that's the individual patient, some of that is the society. And those things just occurred to me as a way to look forward. Longer story than I meant it to be, but that's, yeah.
I mean, and the ways in which what we witness in our youth is set the tone for how we live our lives as adults. So thank you for sharing that. Issues about diversity, equity, inclusion have been core objectives starting your career. The first time I heard you speak at Harvard Medical School more than 30 years ago, you were talking about that. How do they play into academic medicine, into the health sciences, the research excellence? What do diversity, equity, inclusion have to do with that?
So I had 30 years ago, this was, or so, I was the dean of admissions for UCSF. And there was great pressure on affirmative action during those days. And I had to, we were sued and other things, so I had to be prepared to describe what it was we were doing and why. And I had to feel since I felt I signed the letters for people, I had to be able to defend each one of those why I was doing it. And so I'm thinking about diversity, equity, and inclusion and what we were calling it then. And there was the tussle there was anti-affirmative action with a guy named Ward Connerly. And my work in this broader sphere was that because I was the dean of admissions at UCSF, I was brought to be this sort of debate antagonist before the board of regents. And I was much younger then, and I was talking about the medical school only, and he was thinking about the broader society. So we had a real active program, and we had things that we were proud of. And how I described it then, there were three things that we were thinking of. So one is fairness, and that is that we realized that the pathway from where we were to here, it was not the same. And if you get to about the same place, but you come from further, that means a lot. And we wanted to look at who you were, where you came from, and what was fair to you with the opportunity of being able to attend, in our case, a public university. And so fairness and taking it into account the pathway that people had to get here, what they had demonstrated to us characteristics of value when we were making a fair selection. And then the second thing that we were looking at was service. And service to society, we actually did some research. We looked at this, things that we lived and experienced or we wanted to put into print. And we looked at underserved populations and who was likely to serve them. First, underserved is one thing, and then did service make a difference? As doctors, there are people healthier when they have medical care, and the doctors help, and so we determined that was true. And then we looked at underserved regions and said, gosh, those that are underserved are also unhealthy, and who is likely to serve them more in a variety of ways. And we, as everyone knows, but we did some work to show this. Underserved people from those underrepresented communities are more likely to serve those underserved populations. So if you wanted to balance the opportunity for service, you needed to train more people who were more likely to do that work. So that was something else that we did. The third piece was something that we learned. It wasn't a priori, we kind of got to that. And that was the utility of diversity and inclusion. And that is that we actually then, as an institution, improve the quality of our institution by having different perspectives and points of view on rounds in the classroom, et cetera. So those things, so the fairness on one that they're getting, the service at the end, but then for the quality of the institution, the utility of being inclusive was something that we really lived through. And so those were the three reasons that underpin the fact that it's important for us to have a diverse class. So you're going to tell them the wonderful thing, don't you're polite. So let's say we're all here now. I did this in a different way. Let's pretend we were going to do this. So I would show a collage up on the screen, and let's say there are 50 or 80 different images there. the Empire State Building, Fenway Park, the Cat in the Hat, bottle of Coca-Cola, random things that up there, there's a collage. And I show it for 2 seconds. Then I take it down. And I go around the room and I say, what did you see? And it turns out that in having done this, you can see in river 6 or 7 things in that 2 seconds out of the collage. And so I'd ask the first person, what's your name, if I could? Ariana. I asked Ariana, what did you see? Ariana is actually particularly sharp. She'd see 8 things. But Ariana would say, I saw a bicycle, a red wagon, a shark. And that would be great. And then so terrific. And then we go to the next person. And then we go around and that person would see, gosh, the bicycle, but also a sailboat and the Hoover Dam or whatever. And we go around and we find that some people had seen the same things or most of the same things. Other people saw things entirely different than what Ariana saw. And so literally everybody saw the same thing. But what everyone took from it was slightly different. And when you look at the entire room, we saw much more collectively than any one person could see. And that was the experience that we lived through on the wards in the classroom, etc. That bringing more of us there brought things that we didn't know. We'd all looked at the same thing, but we saw different things, and as a collective, we saw it and had more knowledge than we would individually. So that was sort of the underpinning of it, and one of the reasons we've worked for it all along. It's better for us, it's fair, and it's better for society. So
The other thing I'm hearing though in this is, you look for the data and evidence to understand.
yes,
And can you speak to that somewhat, so that I often see individuals, programs, institutions trying to advance diversity, equity, and inclusion in a data-free environment without evidence. Can you speak to why it was important then? Is it important now?
it's that my background and all would tell me that it's really important. I trained and grew up in a place where data and that, I'm a glaucoma specialist, and so I did all the things you need to do to be a faculty member, and so I was always living in that world, and you had to have, we talked about evidence-based medicine, that was an important thing, and this is really evidence-based policy, and so they seem to be very, very important. We want to be good, we want to be better, we want to continue to improve, we want to know what we think works, and then evidence and data are about the best way to do that.
But in this, I think about that, how do you build the capacity to do that kind of research or ask those kinds of questions? As I think about, is it 290,000 students in your system? I think about your role with the Commonwealth Fund and the fellowships and the training, through. What is the role of our academic institutions or those who are supporting this kind of programs to help build the skills and understanding of the need for data in this space?
Yeah, I think all of us have to come to the spaces that we occupy and do our best to understand the culture and elevate them forward. And in academic institutions, we have to do that on an academic basis. And so a lot of the work, how I first was involved in the Commonwealth Fund really is I'd be giving a talk on one thing or another, and the Commonwealth Fund was a great source of that. So I said, we want to do this, and I mentioned the thing about unhealthy populations and doctors, and so we started with that with some colleagues, really they more than I at that point, looking at the impact of having doctors in the community and the outcome of patient health, to say that in fact more doctors makes a difference. And then just in looking at that, I was thinking about the affirmative action programs we had in diversity, and I wanted to look at, well, where were people unhealthy, and we can say, gosh, the minority populations are more unhealthy. And then I said, gosh, what about minority doctors? And there's a gosh, they're more likely to serve those patients. And so we could kind of go click, click, click steps saying that there's a reason for doing this. And what I'll say, if I can, we set up a program, actually, it's been terrific. I will say, a terrific program based on these findings. And the regent, Warren Connerly, who was so antagonistic, started this wave of anti-affirmative action laws and things in the 1990s, was a person who I disagreed with actively, but he was a person of integrity. So he believed that you shouldn't use race to make decisions on opportunity, that was racist. He's an African-American man, so he was kind of a thing that they used him as the tip of affirmative action based on the fact that he was black, but that's a little irony, but he believed that firmly. And so when he was one of my regents, I'm a faculty member, he's a regent, but we put together a program that, we had dinner together, and I shared with them that if we look at these populations, we see that these people are underserved. And he didn't believe that anybody should be underserved. And I said, and these are the people who are more likely to serve the underserved people. He understood that was the case. And so we set up a program that was meant to focus on serving underserved patients. And the qualification for being admitted to the program was that you had a demonstrated interest in or capacity in serving underserved patients, no matter who you were. So you weren't admitted to the program based on who your parents were. You're admitted to the program based on what you wanted to do. And he understood that there was a need, and it was appropriate to train people who were going to meet that need. So he was able to second the program as we brought it forward, although he was absolutely opposed to affirmative action.